We as ophthalmic surgeons in 21st century must know that by 2050, 50% of the world population will suffer from some sort of myopia. That is a big number when you are saying 50%, which means around 3.5 billion people approximately will suffer from some sort of myopia. And with such numbers, the rate of high myopias also increases. We as ophthalmic surgeons, opticians, and refractive surgeons will be acting as sentinel for all these patients and must know how to correct these high myopias. There are three technologies which are currently available to treat myopia. The first one is LASIK. A plethora of LASIK technologies are available to the patients. The second is implantable collamer lenses, ICLs, which can correct a lot of myopia as well. When the patient is unfit for both of these technologies, we prefer refractive lens exchange or clear lens extraction, as I call it. This patient, we have taken it for refractive lens exchange. The patient did not have the budget for ICLs, and we have planned a refractive lens exchange considering the age of the patient and the affordability of the patient. Especially in developing countries where patients are not able to afford ICLs, refractive lens exchange offers a novel technique, and we as ophthalmic surgeons must know how to operate it safely. So I have done the usual steps. Hydration, Rexes are very easy. These patients, because of long axial lengths, have some tendency uh, to have some uncertain phaco-dynamics in the anterior chamber as you start your phaco, but you should keep calm and try your phaco in lower settings in your initial days when you're operating such cases. I have done hydrodelineation and hydrodissection in this patient, and I'm keeping zero phaco with minimal vacuum, and just like that I have grabbed one pole of the nucleus and it rotates and it comes in like soft jelly. It's the same consistency as that of the yogurt that we have, and the phaco is done in no time. The real fun begins after the IA part, when in such high degrees of myopias I'll be implanting around 1.5 diopters of IUL in this patient. Such low dioptric powers are not available in single pieces IUL, so I have ordered a Johnson & Johnson 3-piece IUL in this patient. Remember, as you might be seeing, what I have done is I put visco first to maintain the anterior chamber, and then I took out my phaco tip from the anterior chamber. For me, in these cases, the most important pearl of wisdom that I would like to hand you over is you try not to touch or disturb the anterior hyaloid face. I operate these cases like those of posterior polar cataracts, because once you allow the anterior hyaloid face to collapse, there is a high chances of vitreous tractions giving rise to those retinal tears, those horseshoe tears in the ora area. Once the anterior hyaloid face collapses, the vitreous pulls on the ora serrata, which can result in retinal tears eventually. This is the most important tip that I would like to give you. The second most important tip is how to load a 3-piece IUL. As you can see, you can just rewind the video and look at the technique with which I implanted. I don't give 3-piece IULs to my OTA because he is lacking sufficient experience in loading these IULs. These are a little peculiar to load. The most important thing to consider is to not fold those haptics too much. This is the most important tip. You keep them relaxed in the cartridge and the IUL will be good to go. You'll see certain mistakes in this case. I'll enumerate them so that they don't happen to you. As the case proceeds, I'm going to point them out. I'm done with the irrigation and aspiration part because the patient is young. I keep it a point to clean the bag thoroughly. I'll do minimal AC polishing I don't touch the bag because it's patients with high myopia have floppy bags. They have big macrozomic corneas. The bag is big, it's deep. It would feel like you're operating a in a pit. Axial lengths are very long, anterior chamber depths are very long. We are done with the bag cleaning, and I'll be putting the IUL now. It's a 3-piece Johnson & Johnson Sensor IUL, and just like that the IUL is going in. And yes, the leading haptic is in the AC right now. I'll dial it in the bag and push the trailing haptic just like that. And yes, the IUL is in the bag. The patient had 18 diopters of myopia. It will be a life-changing surgery for this patient. You cannot even imagine the kind of smiles and blessings and happiness the patient has on post-operative day 1. We'll be cleaning the visco now, and as you can see, there is a minimal degrees of haptic plasticity in the trailing haptic. Mind you, you should keep it relaxed. While you should not push those haptics or fiddle with them or nudge them too tightly in the cartridge. That will lead to permanent disfiguration of the haptic, which will eventually lead to decentration of your IUL in the bag later on. And yes, just like that, we are done with the surgery. You can even appreciate the kind of depth this anterior chamber has. The iris collapses just like that. There are minimal chances of iris retropulsion syndrome in these patients as well. In those cases, you can just lift up the iris minimally. And once again, I have not allowed the anterior chamber to collapse. I have put the air bubble before hydrating the side ports and the main ports, so that the anterior hyaloid face remains in its original position. It does not collapse, leading to traction on the ora. This is the second eye of the patient, and this eye had minus 16 diopters of refractive error. Going ahead with the usual steps, the side ports 180 degrees apart, viscoating the cornea for some magnified view, cutting the limbal vessels is important for a good healing in this patient because the patient is young. We need a very good long-term result for this patient. These patients don't have cataracts. These patients generally have visions of 6/9 best corrected. So there is a burden of high expectations on your shoulders which you need to meet. But these patients are very, very rewarding for your career. Imagine what modern technique and technology can do, just removing those heavy concave lenses this patient has been wearing for the last 30 years. All sorts of aberrations, all sorts of jack in the box phenomena the patient suffers from will go. The patient is not able to go on a vacation. The patient is not able to play any sports. The patient is totally dependent. In 21st century, such kind of dependency is a handicap, I feel. And we as ophthalmic surgeons are blessed to make these patients independent of these heavy glasses that they carry everywhere. In this eye, I tried to complete the phaco part with the IA, but I failed. So eventually I took on with the phaco. After I realized that I cannot complete the case with the plain IA, I switched on the phaco tip, and because of the larger bore size, I was able to just take that soft nucleus out in no time. and we'll go ahead with the same steps as the patient's first eye. I operated both of these eyes at a gap of 15 days, mind you, and just like that, I'm not willing to make the anterior hyaloid face collapse. I've put visco first and then I took out the phaco, just like you operate a posterior polar cataract. Once again reminding you, try to not take that phaco probe out of the eye directly. Put some visco first so that anterior hyaloid face maintains its position and there is minimal traction on the ora from the vitreous. And in this IUL, the thing I noted was I put inadequate visco in this IUL, and the IUL, when I pushed it through my injector, it came with a sudden explosive force, which on first glance I felt that it might have injured the posterior capsule, and I had sympathetic overactivity, to be honest. At this moment in time, I examined the bag, and to my surprise and my luck, the bag was intact. So you should always try to go ahead with some meticulous loading when 3-piece IULs are in question. These IULs are infamous for they're really notorious when loading. Don't press those haptics. And yes, the IUL is in an inverse position. It is in the position of the number 5 when we have to implant it in the position of the letter S. But I consciously decided not to tilt the IUL. The patient can manage with 0.5 diopters of refractive error, and as I had cleaned the bag thoroughly, the posterior square edge, the benefits of the patient won't be getting the benefits of posterior square edge, but nevertheless he won't be getting PCO anytime sooner with these IULs. So not tilting the IUL, not rotating this IUL in the bag was my conscious decision. I could have done it, but because of the high axial length and the deep anterior chamber, I thought it would be safer to keep the IUL this way, although it's in the wrong orientation, but the IUL will do its job. Removing the 16 diopters of refractive error was my first intention and my only intention. Keeping the bag intact is the highest priority. Yes. And just like that, the case is over. And this was a fun case. The 2 eyes of a single patient, the need of the hour. We all surgeons must know how to operate these high myopia patients. Refractive lens exchange is a common entity and will be a rampant procedure. That's what I predict for future. That's all from my side. Kindly like, share and subscribe. This is Dr. Semanchal signing off. Thank you.